thank you very much to those of you who've agreed to be a member of the reference group for this work stream around redesign for primary care. For those of you who don't know me, my name is Isabel Hodkinson. I'm a Tower Hamlets GP and a CCG board member, and my particular role at this time is supporting the delivery of new models of care work, of which, of course, primary care is going to be the absolute heart and foundation of any developments that we want to make. We have two work streams that are about developing primary care, but the reference group is working to the redesign work stream, which is very much about, as I said, making sure that we build a primary care offer that will be able to support particularly the Vanguard programme, but also some of the other developmental pieces of work going on across the piece. The Vanguard work has a very strong vision. This is one example of some of the engagement work that's been done, and if I draw your attention to the top right hand corner, very much to do things differently and to plan from the bottom up, that is, starting with the patient. And I think also that one could say the National Health Service historically has really been the National Illness Service, and that at this point I think we are actually thinking much more widely about what actually health and well-being is about, and thinking much more into what happens in our communities and the ways in which people live their lives. The other big shift in culture is away from the doctors are going to fix you idea. So it's about what matters to that person rather than what is the matter with you. And of course we've been very shaped by the work the National Voices did around the I statements, and the I'm Still Me is an extension of that work done in partnership with UCL partners, focusing particularly on the older person's experience, and the strong themes around being able to be independent, being able to take their part in decision making, and continuing to be involved and to be supported in retaining their autonomy for as long as possible. And a crucial corollary of this is that actually what we define as being the job of service delivery, the outcomes that we're looking for, that at least some of them need to be defined by the person rather than by us as providers. And some of those outcomes are identified about what's important to this individual. So things like, what is it that helps me cope? And what into the future would I want to mitigate against or plan for? And then, of course, we still have to do the medicine, so what's important for them will be based around evidence-based medicine, but very much tailored to that individual. As we see increasing degrees of multimorbidity, it's clear that sometimes the disease-specific pathway is no longer really relevant for that individual, and we need to tailor it accordingly. And of course, that as the levels of complexity increase, it's no longer good enough to just manage the individual diseases. We really have to work together around that person across the different teams who are involved. And crucially, as general practitioners, we need to continue to remind people that we know very well that good relationships, building trust, knowing each other as human beings, and that continuity of care are well known to provide better outcomes. I mentioned earlier on that as well as the Vanguard programme, there are various other transformation pieces of work going on. TST stands for Transforming Services Together, and it's a transformational piece of work going on across a wider footprint, including Waltham Forest, Newham and ourselves, and it's very much about reframing the whole offer, in particular around hospitals, so that moving a lot more care close to home, working together as a system rather than just the individual provider organisations, that the hospitals that we have got are strong and sustainable, and that they're doing things that only they can do rather than things that could be moved out of hospital, and obviously that we maximise the use of the enabling resources that we have in scope. And so to reframe that, we're saying that we're going to move stuff out of hospital, there's more care out of hospital. But if you look at the very top button, the whole system will work to help you stay well and manage your health better. So again, that theme around starting with a human being and thinking very much from a prevention perspective about what will work to help them stay healthy rather than just waiting until they get ill. So we've actually got a big ask of primary care. So as well as what primary care already delivers, that TSD programme is going to ask us to do more. Tower Hamlets actually has a really good base to start from, in that we already have GP networks delivering care packages for long-term conditions and prevention. And those networks are funded so that they provide another layer of management resource, and that the model of the way that we funded these pieces of work has been very much around a very, very strong outcomes focus. And in terms of the quality, this has been very, very successful. So first of all, there's a much better equitable and standardised offer, and we have had significantly improved outcomes across things like biomedical markers for diabetes, delivery of NHS health checks, and achieving high levels of immunisation uptake. So one of the things that we learnt when we were setting up the networks, and from some preliminary work around the Diabetes Year of Care programme, is that we really have to think in a system way. There's a tendency perhaps to focus only on one bit of this, but that we recognise that having committed providers is important, the staff is important. Crucially, with the network, learning was also about how very important it is to have really robust organisation supporting processes. The commissioning has to make sure that we're incentivising the right things, but the bit that I think historically it's tended to get missed out is actually engaging patients, carers, the communities in activating them to support them themselves. And some of the elements of the ongoing work that are taking place right now are, in particular, we've talked about incentives, so that we are looking at new models of allocating funding. The current way that hospitals get paid is by something called tariff, where they get paid an amount of money for each piece of work they do, and it is well recognised that this incentivises the wrong kind of activity. So there's a challenge about how we do that better. I've already mentioned outcomes-based commissioning within general practice. We'd like to see much more of that across the system. It's not the way we've been working with hospitals or community health services. That we need to learn together. So CPEN stands for the Community Education Provider Network, and it's a developmental journey using money from Health Education England, but using it collectively rather than by organisation. The Wellbeing in Tower Hamlets programme is the next iteration of the resource that has been put in through what was used to be called social prescribing, but is very much about a commitment to developing and engaging relationships with the community and voluntary sector. And then IT and informatics is a big work stream, both across the wider sector footprint, but also within the Vanguard programme. And there is quite a lot of research that shows how effective organisations structure themselves, and this is actually American work, but gives some headlines about the kinds of things that make a difference. So the science and informatics, that we need to capture what we're doing, and that has to be electronic so that we can then interrogate it. That the science, the health science, the real-time access to knowledge, so we're based on the best quality evidence. We have to work as partners. Patients and clinicians bring different strengths, bring different energies. We have to get the incentives aligned, and that we are absolutely transparent about what we're funding and what we expect for that funding, and that we recognise that there's a continuous need to improve, and that we have leaders who are not afraid to say we could do this better, but equally that the system is supportive of that learning journey. So getting the data right is very, very important. And again, within general practice, we've actually got quite good infrastructure around some of the clinical dashboard work, led by the Clinical Effectiveness Group. We all have the same software, which is called EMIS. Our information flows into a data processing area, which is the thing with the big green circle, and then the data can then be interrogated once across the piece, so that the search is a single borough-wide search which powers both the call and recall and the outcomes payments, and that the networks are then encouraged to work from this dashboard as a way of their improving quality work. So I've summarised quite quickly that there's a lot going on. We've got primary care as the really crucial base for delivering some of this very ambitious system change that we need to see in order to end up with health and social care provision which is really centred around the human being. This CCG primary care reference group is going to be a really important component in helping us get this work right. We had a preliminary meeting on the 16th of December which helped us shape our ideas about what this group should be like. So the high level take-home messages about how this group is going to function. This is not a decision-making body. The primary care programme reports to the CCG board, so decisions will happen there. Obviously, anything that impacts on contracts or working conditions would also have to go to the LMC, so decisions would happen there. As far as the reference group is concerned, we originally were thinking in terms of a clinical reference group, but a very clear steer was that the perspective of the reference group needs to be wider than that. If we're trying to develop person-centred, community-oriented care, we need those voices in the room. So, members of this group are not representatives. We're asking you to come in the eye. You're joining us to share your own personal expertise and perspectives. And then the final piece of advice from some of the GP care group members was that it was really important to understand that different bits of Tower Hamlets are really different, and that where we could, we were going to try and have the widest possible geographical spread for people from within Tower Hamlets. So I've explained about the governance within the CCG and obviously the role of the LMC. However, we are going to be working very, very closely with the Vanguard programme, which sits with FIP, which stands for the Tower Hamlets Integrated Provider Partnership, and is made up of the GP Care Group, which is the umbrella organisation of all 36 GP practices, the East London Foundation Trust, who provide our mental health services, the London Borough of Tower Hamlets, and Barts Health as our main acute provider. The CCG is very involved. We have representation on the programme board. Jane Milligan, our chief executive, sits on that. We have strong engagement with all of the different working groups, and in fact many of these work streams have now become joint, for example the IT and technology, and also we make sure that we pull through work that's been done across the sector more widely. The Stakeholder Council is in the process of being set up, and we will need to look at how you, the reference group, link up with the Stakeholder Council and the FIP Vanguard Clinical Reference Group, so that's a conversation to be had. So thank you for listening. I hope this has helped set context for those of you who have not been very familiar with this process already. Our commitments as a programme and what we're asking you to do is that we're not going to jump to solutions, and we're asking for time to spend diagnosing and understanding issues. We're really aiming to co-produce any proposals that come out of the work, and that we will consult widely, and that the reference group is an important critical friend in this process. But there will also be lots of other ways to get involved. So all the ones that we currently have, the Tuesday evenings, the locality commissioning groups, practice one-to-ones, we're going to post stuff on the GP internet page, but also to hear from you about ways in which you would find it helpful for us to widen engagement. So we're looking for help again from you about how to go about this journey. So once again, thank you for agreeing to be a member. I hope this context setting has been helpful. You may well have additional questions. Please don't hesitate to address them to myself, Jenny Cook or Joanne Sheldon, and we hope that this journey will lead to the kind of services that the residents of the borough need and deserve. Thank you.